Hello. Good morning, everybody. It's time to get started, and Dr. Gessel is going to introduce our speaker this morning.
Well, it's my distinct pleasure to introduce our third or fourth interventional fellow, Arslan Shaukat, here to our podium. Arslan, as far as I know, nobody has told me anything otherwise, is doing a great job in the interventional cardiology fellowship. He is going to finish in about 4 months, yeah? And good news, he told me that he's already having a job at the Phelps County Regional Medical Center in Rolla, Missouri, where he's going to be an interventional cardiologist. He joins us from the famous Aga Khan University, then did his internal medicine residency in Indiana, did cardiology in Kansas, and is now currently doing some training at the Hennepin Medical Center, who is collaborating with us in interventional cardiology, and then joining us again too later in the year in our lab. He also has done, and he was the first interventional fellow who does that or did that. He did a 1 month rotation in vascular surgery, so hopefully we'll have some more collaborations in that sense too. So thank you very much for giving us an update. Thank you.
I think this is working. Right, good morning, everyone. Thank you for coming. So this morning I will be talking about expanding the horizons of percutaneous coronary intervention and talking about complex high-risk PCIs. So the objectives of my presentation will be to describe what we know right now, as of right now, in terms of the existing data about high-risk PCI, and then I'll be talking a little bit about the role of mechanical circulatory support in this group in particular, and then also show some case examples from our own institution here. So I think it's always good to kind of look back at history. I always find it a little bit fascinating. But this is kind of the timeline and some of the really landmark events that have happened in the world of angioplasty and PCI. So initially, back in the 1960s, Dr. Dotter described sort of the initial angioplasty technique called the dottering technique. But really, the major landmark event happened in September 1977 when this gentleman by the name of Andreas Grunzig was in Switzerland, and he actually did the first angioplasty in a patient, and it was a 38-year-old male, so actually pretty young, who had a proximal LAD stenosis and was successfully intervened upon. And since that time, really, that revolutionized the field. And after that, other significant events, obviously in the mid-'80s, we had the first stent developed by Dr. Sigwart and Puel. And then after that, really, it moved into the world of acute MIs, and since then, stent technology has gradually gotten better and better over the years, to the point that now we have looked at completely bioresorbable vascular scaffolds, although those are sort of on hold right now. But really, we have come a long way. So this is actually the pressure tracing from the very first angioplasty that Dr. Grunzig did. It was a double lumen, balloon catheter. So the balloon was mounted on it and had an additional lumen to provide perfusion to the distal coronary bed. So approximately, you can see this is the aortic pressure. This is the pressure at the tip of the catheter. And then they advanced it towards into the stenosis, and it really dropped. And then they performed dilatation, and it really got better after that. And this is actually the angiogram. Actually, pretty good resolution there. You can see the kind of the proximal LAD disease and really good results. Interestingly, this gentleman is alive and well 40 years later. So there you go. And so last year was a landmark event in the sense that it was 40 years since that first PCI. So obviously, a lot of discussion about how far we have come and what could be the future directions in this field. And so I feel like one of the things that certainly is the future is complex high-risk PCI. And why is that important? As you all know, the burden of coronary disease is still huge, despite our excellent advances in medical therapy. About 15.5 million adults have it. A lot of people have new events every year. And as the population gets older, and we see that a lot of these people actually present, when they initially present, they present with complex and they present with severe coronary artery disease. And it has been shown that in this group, revascularization does lead to improved quality of life, at least, and also reduced adverse events. Now, we also know that in the past decade or so, revascularization rates have declined for different reasons: better medical therapy, or better understanding of treatment of stable coronary artery disease. But an important thing to note is that the group of patients that is actually least likely to get revascularized are patients who are at high or inoperable surgical risk, those who have multiple comorbidities, patients with heart failure. A lot of times these patients don't even get referred to be considered for revascularization. And some of that, I think, comes from the early experiences with PCI, particularly in the previous decades, where success rates were not as great, complication rates were higher, especially in this type of complex group. And other things were that there was a lack of technical expertise. For this subset, there was a perception that procedural success is not that great. There's also been confusion about what is the real indication for PCI in this population. And there is admittedly a lack of data on the benefits of revascularization, even now. And I'll talk about that as we go along. And these patients are excluded from most clinical trials. So if you look at trials like Syntax or other trials that compare, let's say, PCI and CABG, their exclusion, they will include patients who are candidates for either bypass or PCI. So hence, this group will generally get excluded from those clinical trials as well. And obviously, there's always a concern, particularly in the interventional world, about reporting of adverse events. So that deters operators to some extent. And now, we know that PCI has evolved greatly over the past couple of decades. We also know that CABG, at least in the intermediate and high Syntax groups, is better than PCI and medical therapy, although that is gradually being challenged somewhat. But there remains that group of patients who are either inoperable, that surgeons will refuse to operate, or they're just very high risk for surgery. They may have had a previous CABG, or it may be the patient's choice, where they say that I really don't want to have an open heart surgery. So that brings us to this, and this is, I think, how we should not be thinking. The gentleman saying that instead of really risking anything new, let's just play it safe and continue our slow decline into obsolescence. So we really should not be thinking like that. So then, what is high-risk PCI? How do we define it? This actually chart here, it's a little busy, but the purpose was that this diversity of criteria has been used in different studies and trials to define this group of patients. So really, a lot of heterogeneity. There's a lack of sort of consensus about what are the criteria that should be used, and that makes comparisons between the studies that have been done, trials that have been done, a little difficult. And there are also factors, as we all know, that are not really captured in our standard risk calculators. And so at this point, the definition is somewhat arbitrary. But really, this group should be defined by a combination of factors. Now, if you look at this chart, this group lies in any one of these overlapping areas. So there's really three areas. One is the patient-specific factors. Then there are lesion-related factors, so how complex their coronary disease is, how challenging it would be to treat, and then what their hemodynamics are like. So do they have depressed LV function? Do they have concurrent valve disease? So it's really when you combine a number of these factors in the same patient, it puts them at a higher risk for not just procedural and short-term, but long-term adverse events. So really, that's how we should look at this group. But like I said, a universal definition at this point is somewhat elusive. And then the other question that arises is what model of risk stratification should be used? And there is a lack of risk scores that are validated in this group as well. We also have to think about factors like age and frailty, how do they play into this? We know that both of these groups have a higher risk of adverse events and mortality. And certainly, for example, in the TAVR world, there's obviously a lot of interest in the frailty aspect and the futility aspect as well. So this group of patients has basically become a subset of interventional cardiology, which is called CHIP. There's various training courses for that as well, and so it basically stands for complex, higher risk, and indicated patients. And so this group is basically a high risk, higher reward group where you take on greater complexity, and so the risk is higher, but you're also likely to get more reward for it. And one of the things that you can do to reduce the risk in terms of the procedure is to use mechanical circulatory support. And so that is one of the things that comes when we plan these high-risk procedures. One is which mechanical circulatory support should be used, whether it should be used, and should it be done electively, should it be placed pre-procedure, should it be a standby device. So really, the one consensus that everyone has is that in the end, it needs to be a heart team approach. So really, everyone has to come together, including the surgeons, the cardiologists, and everyone else, to decide really on all of these questions, whether the patient is a candidate for complex revascularization, and then what strategy should be used for them. Now I'm going to talk a little bit about the mechanical circulatory support devices that we have or we use for these procedures. Now, a good device or the ideal device is one that has that can be placed fairly easily without really needing much surgical input. It's easy to maintain, easy to initiate, easy to maintain, and gives you the kind of support that you need for the ischemic myocardium and also for the systemic circulation as well. If we look at the data about their use over the last decade or so, it has increased quite a bit in terms of the relative increase. Overall, the overall use is still pretty low. And the one good thing is that in these patients in which these devices have been used, the mortality has decreased, which goes to, I think, just that we've learned to use them better, and that devices have also gotten better as well. So this is just kind of a chart showing all the various devices we do have right now, and one of them is sort of investigational, but I'll talk briefly about it. So essentially, we have the balloon pump, the Impella, which comes in three forms. The 5.0 requires a surgical cut down, and then there's the two that we use percutaneously are the Impella 2.5 and then Impella CP, of course, and then there's via ECMO, which of course at our institution we have great experience with. So talking about the balloon pump, it's been around for decades. Most of us are pretty familiar with it. The concept was initially actually described in the 1950s, and the first implant actually was in 1967 in a young female with cardiogenic shock. At that time, it was not percutaneous. It required a cut down and was a 15 French device, so fairly bulky. And this is actually one of the first publications that came out in May 1962, where they described its use. And so it's been around for a long time. So what is the status right now? And so in a registry analysis of the CAP-PCI registry, it's used in only about 10% of all high-risk PCIs. So it is still used, even though we don't consider it sort of first line at this point, but around the country it is still used. And but however, with multivariate adjustment, they found that there hasn't been really much of a difference in outcomes in terms of hospitals that do use it versus those who use it less. And there's some conflicting data in terms of at least retrospective data that we have from the NIS database regarding the benefit of using other devices over the balloon pump. And these two studies had actually entirely contrasting conclusions. So this brings me to really the one randomized control trial that has been done for the balloon pump in this group of high-risk PCI patients. And this was the BCIS-1 trial, published back in 2010 in JAMA. And it was a prospective multi-center study, had 300 patients. And they basically included people who had a low EF, so severely reduced EF, and a large amount of myocardial risk. They used a score called the Jeopardy score, which really tells you how what their extent of coronary disease is. And so they included this group. And the results were not very encouraging. At 1 month, there was really no significant difference in the major adverse events and no difference in mortality between those who had an elective balloon pump versus those in which there was no balloon pump planned. Their 6-month mortality was also similar. They did find that there were more minor bleeds with the balloon pump. One thing they did notice, though, was that in the balloon pump arm, there was less peri-procedural hypotension. So the procedure was somewhat better tolerated. But overall, it did not support the prophylactic use of a balloon pump. But they suggested that perhaps there is a role of having it as a standby device, at least, because there were there was about 18% of patients who crossed over, so ended up needing a balloon pump because of hypotension. So at least having it on standby is good, because at this point we really cannot predict which patient might end up really requiring it. Interestingly, they did a long-term follow-up of this study as well. So they did a 5-year follow-up of their mortality, and this is all-cause death. So what's interesting is that the curves, as you can see here, continue to diverge over time. And what they found was that at 5 years, it was mortality was actually significantly lower in the group that the balloon pump was used in. But some of the caveats to that is the cause of the death is not really known. Was it the balloon pump was the use of the balloon pump that was related to this? So what is the cause and effect association here? We don't really know. And the study was not originally designed to test for this long-term all-cause mortality. But it does raise the question of having future studies that have longer-term follow-up and actually are designed for that as well, and hopefully can be randomized in a similar manner. But we do see this signal in other trials as well, and I'll come to that. Another device that is out there but is not used a whole lot is the Tandem Heart. So this is a centrifugal continuous flow pump. It actually has a left atrial cannula and a femoral cannula. It is able to provide a fairly robust amount of support, and it is approved for both high-risk PCI and cardiogenic shock, at least for short term. But the problem with the device is that it's a high-profile device, and placement is not straightforward. You do have to do a transseptal puncture, and because so that you can place the inflow cannula in the left atrium. So there's been concerns with bleeding and vascular complications mainly. It hasn't shown any survival advantage over a balloon pump in cardiogenic shock and MI, and there's really no randomized trial in high-risk PCI for this device, and overall the data is not robust. This is one study that was done at the Mayo Clinic, where they looked at their own experience with the Tandem Heart. They had 54 patients. Overall, the mortality was the survival was pretty good, but what they did see was that major vascular complications were about 13%. So as I said, that's a concern with this device. So now we come to the Impella, which is an axial flow rotary pump, and it sits across the aortic valve. There's an inflow and an outflow, and it basically unloads the LV. And as I was mentioning, there's 3 types, and the 2 percutaneous ones we use are the 2.5 and the CP, and both have been approved for high-risk PCI. The 2.5 device is called 2.5 because the support it provides is about 2.5 liters per minute of cardiac output, and the CP can give you up to about 4 liters of support. So when we look at the data for Impella, there's a registry. There's an ongoing prospective registry in the U.S., which is called the U.S. Impella Registry, which is originally for the 2.5 device. And what they've seen from their registry data is that revascularization success is really high, 99% in these patients, and they have noticed that ejection fraction and functional status improves in about half of these patients. They do end up needing less ICDs. They have lower mortality and adverse events compared to a historical cohort of patients with similar characteristics. And so really their survival is really pretty good, considering that they are a pretty high-risk group, 88% at 1 year. And this is lower than what their surgical predicted mortality would be if you use the SDS risk score. And the rate of major vascular complications is 1.7%, which is also not bad at all. So then this is actually one randomized study that has been done for the Impella. So it was a randomized control trial which compared the Impella 2.5 versus the balloon pump. And this was called the Protect 2 study. The Protect 1 was just a small sort of feasibility study. And so the Protect 2 study looked at patients who had either unprotected left main or a last remaining coronary artery and a low EF of less than 35, or they had triple vessel disease and an ejection fraction of less than 30%, and they were randomized, as I said, to either balloon pump or an Impella 2.5. And so it had initially had 448 patients in the intention to treat, but then some of them did not really meet the protocol criteria. So 427 patients were in the per protocol population. So at 1 month, there was no significant difference between the two groups in the intention to treat population. However, at 90 days, there was a strong trend towards the Impella in the intention to treat group. But when they looked at the per protocol population, there was actually a significantly lower rate of events in the Impella group, although this was mainly driven by repeat revascularization. Mortality was not significantly different. MIs were not significantly different. But overall, the adverse events were significantly lower. And then they did a subsequent analysis of their data with a less strict definition of MI. So initially they had used a cutoff of 3 times the upper limit of normal for the CKMB. Now they used it, they said that those MIs may not be as clinically significant, so they used a cutoff of 8 times the upper limit of normal. And with that, they found that at 3 months, both adverse cardiac events and adverse cardiac and cerebrovascular events were lower in the Impella group. However, some of the criticisms are that the trial was terminated early due to futility. It was only at 69% enrollment. It did not actually reach its assigned primary endpoint. So these conclusions may be somewhat more hypothesis generating at this point. But as I mentioned earlier, there was a late benefit that was seen. So benefit seen at 90 days more so than 30 days. So it raises the question, is this because they have more stable hemodynamics during the procedure? Is it because these patients end up receiving more complete revascularization because they have more support during the procedure? So we do need further studies, larger studies, and again, with longer term follow-up to answer these questions better, I think. And then they also compared just to see, does this sort of replicate in the real world? They looked at the comparison of real world patients versus the patients that were in the Protect 2 study. And so basically they used the US Impella registry and chose patients who would have met the criteria for the Protect 2 trial. And interestingly, in the registry patients, so the real world patients, you also saw a significant reduction in patients in NYHA class 3 and 4 heart failure, so about a 42% reduction. While in the Protect 2 arm, there was also a significant reduction. It was somewhat less though, 28%. But it goes to show that revascularization in these patients does lead to functional status improvement and improved quality of life. And so these are sort of other hard endpoints comparing the registry patients and the Protect 2 patients. There were actually better outcomes, if anything, in the registry patients. Mortality was somewhat lower, but not significantly different. MIs were actually lower, but that may have been because of the way that they were documented in these patients. But basically goes to show that even in the real world, you can replicate the type of results that they got in the PROTECT-2 trial. So this is in a meta-analysis of all the studies. So as I mentioned, this is the only randomized controlled trial, and there's other retrospective studies. So in total, in this one, there were 12 studies that they looked at, about 1,300 patients, and 30-day mortality overall was about 3.5%, and MIs 3%, major bleeding events 7%, and vascular complications close to 5%. Now this device, I'll just mention briefly, it is still investigational. It's called a HeartMate Percutaneous Heart Pump. And what it is it's a similar concept to the Impella. So again, it sort of sits across the aortic valve there. It is a 14 French device, but it has a sheath over it that once you unsheath it, it becomes a 24 French device. And really what that does is it just provides you more support. So more than 4 liters is what they claim. The feasibility study has been done. It's been done in Europe and South America, and they found it to be feasible and efficacious. And right now there's a SHIELD 2 trial that is enrolling across the U.S., and they're going to compare this device to the Impella 2.5 in high-risk PCI patients. So in the future we may see this as well. Then lastly, I'll talk about ECMO, which here, of course, we use quite a lot at our institution. This device, it has been around for a long time as well. First approved in the 1950s. Initially for use, and it was supposed to be used mainly for cardiac surgery. And we know the VA type of ECMO is essentially a modified cardiopulmonary bypass, which gives you non-pulsatile continuous cardiac output. The major advantage is that it gives you complete cardiopulmonary support. And so if there's respiratory issues, it can support that as well. The one downside, though, is that it does increase LV afterload and wall stress because the outflow goes into the distal aorta. So people have raised that concern that if your myocardium is very ischemic, that could cause problems. And as we know, it does require quite a bit of collaboration between different parties, so not just cardiologists, but the surgeons, the cath lab staff, anesthesiologists, and perfusionists. So in a lot of institutions, they feel that this is a drawback for the device. And obviously needs anticoagulation and has some of the contraindications that are actually common with some of the other devices as well, so such as the Impella as well. So severe aortic insufficiency, severe peripheral vascular disease, things like that. So what do we know about it? We know that in patients with STEMI and cardiogenic shock, patients and in cardiac arrest and cardiogenic shock from other causes, it does really well. It's well validated. However, for elective high-risk PCI, we don't have a lot of data. There's only single center studies and case reports. And in those small studies, as I'll describe a little bit later, it has been found to be feasible and efficacious, but vascular complications have been a concern. And there's no randomized trial and no actually meta-analysis really available at this point for the high-risk PCI group. So any guidelines we have are based on just expert consensus. So these are some of the smaller studies that have been done. This one published back in 2007. For the ECMO described, it has 15 patients. They were successful in 14 of them. All of these patients did get weaned off of the ECMO in the cath lab. They did not have any vascular complications. They didn't have any in-hospital really events. And in a follow-up of 15 months, there were 3 cardiac deaths in this study. This study was done in Korea, and they had a total of 19 patients where they used ECMO for support with PCI, and 10 of them were elective or non-emergent ones. And they had a longer follow-up of 541 days at mean follow-up. And really in that group during the long follow-up, there were 2 non-cardiac deaths. So really patients did pretty well overall. This study was more recently published. Also, this was from Europe, had 12 patients. All of these patients were high risk for CABG. 10 of the 12 had left main stenosis. And they weren't able to achieve complete revascularization in most of the patients, which I'm not sure exactly why, but they only had one hemorrhagic complication, one patient needing dialysis, but at 6 months, really no death, no MI, no stent thrombosis. And 2 patients needed revascularization, but it was not in the target vessel. So all in all, to kind of put this all together, I would say that mechanical circulatory support has a solid physiological basis. However, some of the results have been equivocal and some of them have been sort of mixed. So overall, their use remains modest at this time. All of the devices do have potential use, but perhaps not every device is for every patient, and perhaps not every patient needs it. And as I mentioned earlier, it really should be up to the heart team to sort of decide that. Now, what do the current guidelines tell us? And unfortunately, they don't tell us a great deal at this point. These are guidelines, last PCI ones in 2011, where they give a class 2B level of evidence C to the use of support devices in elective high-risk PCI patients. And the other thing to note is that how do they define these high-risk patients? So only a few criteria here. The one is unprotected left main or last remaining vessel, or if they have a vessel that supplies a large territory with severely depressed LV function or cardiogenic shock. However, in 2015, there was a consensus statement that was put out by SCI in collaboration with other societies. And so they gave a list of really indications for using percutaneous mechanical circulatory support. And one of them that they mentioned is high-risk PCI. And how they describe these patients is patients with severe LV dysfunction and complex coronary disease involving a large territory. So somewhat similar to the ACC, to the guidelines that we have. So overall, the body of evidence does continue to grow. The devices are FDA approved, and as I mentioned, the expert consensus document is also supportive of their use. Now, the other question that obviously we think about is there benefit to doing high-risk PCI in these patients, as I mentioned earlier? That's one of the things that we don't really know a whole lot about. Now, this was one study where they actually looked at the effect of high-risk PCI on reverse remodeling in these patients. It was a sub-study of the PROTECT 2 trial, and this subgroup, actually all the patients in the trial were supposed to get echoes at 30 days and 90 days, but not all of them ended up getting them, and some, the image quality was not adequate. But they defined reverse remodeling as an increase in ejection fraction of at least 5%. And as you can see here, sorry, it's a little difficult to see, but half of the patients, basically, so 184 patients, and 50% of them showed remodeling and 50% did not show LV remodeling. And so this is sort of showing the change that occurred. So an interesting thing to note is that in the reverse remodeling group, the baseline ejection fraction was lower. So, and what they found was that actually that was one of the predictors of reverse remodeling. So patients with EF less than 25% were actually more likely to remodel, which again goes to show that it's actually the sickest of the sick patients that may actually benefit more. So the baseline EF was lower, and it did improve by about 13% in this group, and their end systolic volume also significantly decreased. And then they looked at the clinical events in these patients based on whether they did have remodeling or did not have remodeling. And so significantly lower adverse event rate in patients who did have reverse remodeling, which is something that we expect from knowing what we know from heart failure studies. So a much lower composite endpoint, driven mainly by spontaneous MIs in this group. And then they also looked at sort of stratifying the degree of remodeling by the EF change, and so the adverse events were progressively lower as there was greater remodeling. So in patients who had a change of EF of more than 10% had the lowest adverse event rate. So this is actually a study that came out quite recently, and so as I've been mentioning so far, most of the criteria, all of the studies include patients with severely depressed ejection fraction. But we know that there are patients in this high-risk group that may have normal ejection fraction or close to normal ejection fraction, but they're still considered for mechanical circulatory support because they have a number of other comorbidities. So this study essentially, it's still in press, but it looked at exactly those patients from the global CVAD registry. So there's a global registry of these devices as well. And so they looked at patients who had high-risk PCI with either a 2.5 or a CP Impella, 661 patients who were severely reduced ejection fraction, as you could call it, less than 35, and about 230 with an EF more than 35%. So really what they found was, and this is short-term follow-up, but at 30 days, the event rates were not significantly different. So this is the mortality, and this is combined adverse events, and they were not significantly different. And looking at all the events in separately, again, no significant difference in the individual endpoints as well. So really what they concluded from this study is that there is a group of patients in this high-risk group that do not have depressed LV function, but they have other severe comorbidities, or they may have complex coronary disease. And so they're still considered for high-risk PCI with support. And in these patients, the procedure is feasible, safe, and does achieve favorable outcomes. Now, at the end here, I'll describe our experience here at MHI with ECMO-assisted elective high-risk PCI. And I'll go through some cases here. So the first case I have is of a 79-year-old gentleman. Usual risk factors, actually came to us with a late presentation of anterior STEMI. I think his troponin was downtrending at that time. He had already gotten akinesis of his anterior wall. His ejection fraction was 35 to 40%. This is his angiogram. Try to get the best view, but as you can see here, again, so there's basically severe distal left main disease, and there's severe proximal LAD as well. And the other thing complicating his picture was that he had severe peripheral vascular disease on both sides. And really, there was a lot of difficulty in even doing a diagnostic angiogram. So he got an MRI. His LAD territory was non-viable. And obviously, for that reason, he was not considered a good surgical candidate, as there would not be benefit in putting a lima across. So he was planned for a high-risk PCI. And in this case, because of his severe peripheral disease, he was done with a right axillary and a right femoral vein cannula for the ECMO. And this was done with support of our cardiovascular surgeon. And really, at the end, got an excellent result there. As you can see in the left main, he ended up needing only actually just 1 stent there, but really an excellent result. He was decannulated surgically in the cath lab. He did not have any events while in the hospital, and he's doing well at 1 month follow-up. Second case is of a 91-year-old gentleman. He actually was getting evaluated for a TAVR. Had severe aortic stenosis. He was having near syncopal events. He was having dyspnea on exertion. But for a 91-year-old, really excellent functional status. And of course, that's why he was being considered for TAVR. He came for his scheduled angiogram prior to the TAVR, and this is what we found. So really critical distal left main disease there. A little difficult to exactly know if it was extending into the LAD and the circumflex there, but certainly very critical distal left main disease in a 91-year-old gentleman. His EF was preserved, however. So he was not considered a CABG mainly due to age, even though he was a very sprightly 91-year-old. So he was brought for a planned high-risk PCI with ECMO support, and really this was just the final picture here. An excellent angiographic result there. I think he had 1 stent going from the left main, this is the LAD, and then 1 into the circ and the circumflex and obtuse marginal branch there. And so in his case, the cannula were actually percutaneously removed. We used the pre-close technique in the cath lab. He did not have any hospital events. He's doing really well at 1 month follow-up. And I don't think we did anything to discourage him, but he's not interested in a TAVR at this time. I think he's just doing so well. So the last case is a somewhat different anatomy, but this was a 72-year-old gentleman who had had a previous CABG way back in the 70s, and he had a vein graft, which is a Y graft going to the LAD and the OM, and a vein graft to the PDA. The vein graft to the PDA was known to be occluded. He's a fairly sick gentleman with multiple comorbidities, VT, ICD, chronic kidney disease, EF of 20 to 25%, severe pulmonary fibrosis. And he came to us with chest pain, transient elevations, ST elevations in lead V1 and AVR, which really is an ominous sign, and a mild troponin elevation. And since we knew that vein graft is really his sort of last remaining conduit. And this is what it looked like. You can see there clearly there's a severe stenosis there, and it's a Y graft, goes to the LAD down there, and the obtuse marginal over there. So at that time, there was a discussion held with cardiothoracic surgery in the cath lab. He was not felt to be a great surgical candidate because of his previous bypass, and he also had respiratory lung issues. And so the decision was made to proceed at the same time in the same procedure. An ECMO was placed, and then proceeded with PCI, and really got a really good result there. His ECMO was decannulated within the first 24 hours. His hospital course was a little bit rocky. Had some VT, had some ICD shocks, pneumonia, but his ejection fraction actually improved significantly to 51% on the echo that was prior to discharge. And at 1 year, he had no major adverse events. He did end up passing away about 2 years after the procedure, but really did well, I think, until that time. So this is kind of what our data is here so far. So we have, sorry about the busy slide, but we have 8 patients that have had elective high-risk PCI with ECMO support, mean age of 71, fairly high-risk group with the mean ejection fraction of close to 30%. Their STS risk score for mortality is about 5. Their mean syntax score is about 26, right there. And most of them had left main, and most of them actually just left main bifurcation disease. So pretty high-risk group. And what we've seen is in all these 8 patients, there was only 1 hematoma, which was clinically insignificant. There was 1 major vascular complication. The mean hospital stay was about 7 days. 5 of them were surgically decannulated, and 3 of them percutaneously. We were able to wean ECMO in all of these patients. They had no adverse events in hospital or at 30 days. And we have 1 year follow-up for 5 of these patients, and they have not had any major adverse events in that time period. So in conclusion from our data, we can say that ECMO can be successfully used for hemodynamic support during high-risk PCI. And I think it really is up to the experience of the institution with the use of these various mechanical circulatory support devices. Now at the end, I'll just point out some of the knowledge gaps that I've mentioned so far that we have at this point. One is that we don't know the exact size of this high-risk population. So a lot of them may not get referred and for an evaluation or for treatment, so we don't really know. And again, there is no trial that we have at this point to compare PCI and medical therapy in this population. And then in these high-risk or inoperable surgical risk patients, can PCI provide results as good as CABG? Some of the studies have suggested that. In the PROTECT-2 study as well, and in patients where revascularization was achieved in 2 or 3 arteries, did have adverse events and functional status improvement that was comparable to patients in the STITCH trial and other surgical cohorts. So there's some indication of that. Again, we don't have any accurate good risk models to tell us to risk stratify these patients in terms of what their risk would be with PCI versus just getting medical therapy. And the question that is always an important one to raise is what is futility in these patients, and what patient would such a procedure be futile and should not be done. Some of the future directions, I think, for this field, I think one is having a standardized criteria to define high-risk PCI. And I think that having the incorporation of multiple other factors than what we have in the current guidelines would be really very helpful. And I think it really shouldn't be about what device is used, but rather what patient they should be used in. I think that if we're able to form a multi-center registry that tracks outcomes of not just, let's say, Impella patients, but all high-risk PCI patients going forward, that could be used for a preliminary database, and that and data from which could be used for formalized prospective studies and even randomized controlled trials. And then data from these registries could also be used to create an accurate risk model, the like of which we have for other things such as CABG and cardiovascular surgery. So with that, I'll come to an end here. And I think at this point, what I see around the room is this. So, and that's all I have. Thank you.
Questions?
Very nice job. You have a tremendously high bar to try to prove that an ancillary therapy is going to change outcomes, because the major driver of outcomes has to do with the baseline characteristics that are incredibly diverse. And the same holds in diagnostic approaches, and then judging what happens in the long term. There's too many steps in between. That being said, do you know about the amount of people and numbers with ECMO in other institutions and the other publications related to ECMO relative to the 8 patients that you have here? And is there any ongoing approach to combine them?
I'm not aware of any ongoing studies. As I mentioned a little bit, that the data that we do have are all single center retrospective studies, and really with a small number of patients. I think it's one of those things that a lot of institutions, I think, don't think of it as a first line, at least for elective high-risk PCI. We know that it is used quite a lot more for cardiogenic shock, especially acute MI, cardiac arrest, but there is not a lot of data for elective high-risk PCI. And I think probably the Impella is what is used, I think, a lot more, because again, it does not need the kind of collaboration that you need for ECMO, which I think if you have at your institution, like we have it, things go very smoothly, and there really is not much of an issue. But for a lot of institutions, I think just having the Impella that the proceduralist can implant and remove and things like that, I think leads to that. But other than that, I think there isn't a lot of data.
A nice job. Thanks for pulling out those ECMO cases and putting that abstract at the meetings. That's a good work. You know, the literature is divided into elective, stable, supported PCI, and then the other end of the scale is the refractory cardiogenic shock, post-cardiac arrest, and the full-blown cardiogenic shock. But the real world that we deal with is those patients in the middle that have depressed LV function, aren't frankly in cardiogenic shock, but oh, by the way, have elevated creatinine, their wedge pressure might be 33, their cardiac index might be 1.8, there might be RV dysfunction on echo, and all of these things need to be considered. And to John's point, it's a very complex, multivariable situation, and it requires some experience. The field seems to be, and this is quite an expensive device, the Impella, and they seem to want doctors to use it to help them feel more comfortable to do cases they wouldn't otherwise do, which isn't exactly what we as a medical field need. We need, you know, the best of operators to be technically able to do cases and just improve patient outcomes. So, you know, it's nervous factor versus best medical results. So the right heart cath is really an important piece of evaluating those patients. Could you comment a little bit about that?
About the right heart cath? Yes, I think that that's certainly one thing that is increasingly being emphasized lately, especially in patients who are coming with either cardiogenic shock or possibly cardiogenic shock that you're not entirely sure about, especially in acute MI where you're considering a mechanical circulatory support device. And I think there's a new cardiogenic shock initiative that is basically being used, more and more and around the country. And they strongly recommend that you do a right heart cath up front. It really gives you a great deal of information about hemodynamics and can tell you really which patient does need a support device, and also whether they have RV involvement and whether they would benefit from something that provides biventricular support as opposed to just LV support. So I think in those patients who are either close to cardiogenic shock or in cardiogenic shock, I think it gives you a great deal of information, and I think it should be done. I think it's being encouraged a lot because of the information it provides. In these elective high-risk PCI group, I think it is also useful again because some of these patients may be chronically sick, and so even though they may not be frankly decompensated in front of you, they could have a low output state. And what we actually found was, and I didn't have it in there, is that 5 of our ECMO patients, we did have a right heart cath before, and their mean cardiac output was only 4, and their mean cardiac index was 2. So in these patients, it gives you more of a reason to use support, even if you think that perhaps the coronary disease is not that complex, but then you find, okay, they're actually kind of in a low output state, and if anything goes wrong in this elective sort of planned procedure, they're not going to tolerate it. So I think even in the elective group, even if I think you should have it. And then I think during the procedure, as we know, if things start to change, you can get a really quick sort of signal from your right heart cath numbers. Suddenly the pressures start to go up and whatnot. So it can tell you if things are not going well as well.
To Mike's point, I mean, if you look at the papers that you showed, I'm sure there's more, but those are the most prevalent ones. It's always the same authors, right? So it's a very biased group that presents us the data right now, right? At the same time, they are very experienced operators, like Mike just said. They should have known these questions, right? Right heart cath. Is it really the EF that I'm looking at? Because it makes no sense to have EF as an inclusion criteria. I mean, if you talk to any heart failure doctor, there would have been a different inclusion criteria. So all of these data are very biased, and still they're absolutely negative, and we're still asked to use these devices because of what? What is it that tells us we should use the device? So now that you're coming out of this fellowship and you have seen various operators and various devices, what would you use in your own practice? When do you think you should use, and how should you use the very advanced technologies?
Yeah, so I think your point is excellent, that unfortunately we don't have a fantastic risk model. We don't have very detailed guidelines on, okay, this is the patient that you should definitely use it and it will benefit you. But I think that, again, I would put all the different factors together, and the patient looking at sort of, one, like how complex their coronary disease is in terms of what procedural difficulties I might face. Is there a risk for causing compromised ischemia while during the procedure? So how complex the PCI itself is. And then I think that certainly I think in patients with someone with a severely reduced ejection fraction or other adverse hemodynamics that sort of point to you that they're really not going to tolerate if anything goes wrong during the procedure, I would consider it certainly.
Any other questions?
So Mario's comments are right on point in the sense that there's a pressure, the data is pressured. Having said that, I think all of us recognize that this is a very meaningful technology that does support patients and allow for a good outcome in a situation that might be quite difficult. And as our experience grows, I think there'll be continued use of these devices. It was a little disappointing that the PROTECT 2 study wasn't more cleanly positive. But you have to understand that was the 2.5 device, which was doesn't put out a lot of power. The 3.5 is clearly better. And to Mario's point, there's also this hype out there that is pushing the cardiology field in an area that most of us don't feel is necessary. We kind of went through this once before with the CPS registry. I think that was probably back when you were in high school. And we actually did elective supported PCI on femoral bypass on a wide range of patients, and then we came to find out, you know what, most of the time we don't need it. And so I think this is a really valuable field for you and your generation to put clarity on how we can use it to the patient's best advantage.
Right. And I think like one of the things, obviously, as you were mentioning, is I think longer-term data would be helpful. Like as we can see, there's some signal at short term, but is there a longer-term benefit to that? We don't know at this point. And also, we don't have great ways to predict what patient might end up needing the device during the procedure, would develop procedural hypotension. So, I mean, I think that at least having a standby device is always, I think, important, even if you don't electively place it, but you should at least be ready to, I think, use it if you need it. So, but I agree.
Okay, thank you very much. Please stop by and thank our supporters for this week, Novartis, and there's Barb Jones.